Black to Basics by Namrata.
Good morning. I'm Namrata. I'm presenting on behalf of Medicine 3. My presentation is titled Black to the Basics. So Miss N was a 17-year-old college student who presented to our OPD, and her complaint was a history of blackish stains on her innerwear when it was exposed to her urine and then left to dry. Her mother actually reported that since she was a baby, she had blackish stains on her diaper, but they had never sought medical treatment till the age of 17. Urine during passage was clear, and there was normal stools as well. So this was a picture of her innerwear that she showed us, and this was after it was exposed to urine and left to dry for some time. She also took a photo of her urine, and after about 15 minutes of standing, she had noticed that there was darkening of her urine. So there was no history of EC fatiguability, breathlessness, jaundice, history of muscle pains, weakness, fever or rash, no history suggestive of venous or arterial thrombosis, and no drug intake. So based on the history of clear passage of urine followed by blackish discoloration, the only differential that we could find was alkaptonuria. So we asked history significant for that, and there were no family members affected. She's the third child of third-degree consanguineous parents, and both her siblings are well. There's no history of darkening of ear cartilage, dark spots on the conjunctiva of her eyes, no back pain or joint pains, and no breathlessness, palpitations, syncope, orthopnea, or paroxysmal nocturnal dyspnea. On examination, she only had pallor. There was nothing else significant on her general examination or systemic examination. Hemoglobin was 8.4 with a microcytic hypochromic picture, and later studies showed iron that was low with a high TIBC, total iron binding capacity, and low ferritin stores, suggestive of an iron deficiency anemia. The rest of the investigations were not contributory. Urine routine was bland. There was no proteinuria, no RBCs in the urine. So her urine homogenetic acid was positive, and the estimate was 5 milligrams. So above 4 is significant for homogenetic acid urea, which is seen in alkaptonuria. So the final diagnosis was alkaptonuria with iron deficiency anemia, and she's been transferred to medical genetics for genetic studies. The learning points I want to elaborate on, I'll just briefly speak about alkaptonuria, and what I want to elaborate on is an approach to inborn error of metabolism in adults. So I'll just talk on alkaptonuria with this. So this is the pathway that metabolizes phenylalanine and tyrosine from our diet. So finally, what happens is it is metabolized into homogenetic acid, and the homogenetic acid with this homogenetic oxidase, which is the enzyme that is deficient in alkaptonuria, will be converted into mallyl acetoacetic acid. When this enzyme is deficient, it gets converted by an alternative pathway into benzoquinone acetic acid, which is what deposits in our joints, cardiac valves, in the conjunctiva of our eye, and causes this blackish pigmentation. And homogenetic acid is directly also excreted into urine. Now, this is a picture of ochronosis, or blackish discoloration of cartilage, and this is actually the synovium that is pigmented by this benzoquinone acetic acid. Now, other clinical manifestations that we look for in alkaptonuria are actually osteoarthropathies and cardiac valve. It is associated with aortic stenosis because of pigmentation of the aorta and the endocardium as well. The only effective treatment is nitisinone, which is a molecule that prevents conversion of homogenetic acid into its metabolites. And the other therapies that were used before, like vitamin C in the diet and dietary protein restriction, have not been shown to be effective in the treatment of alkaptonuria. Now, I wanted to highlight an approach to inborn errors of metabolism in adulthood. So when inborn errors of metabolism present in adulthood, usually it's not one of the first differentials that we think of, because many IEMs present in childhood. But because of improved detection by dried blood spot testing at birth, and because of therapies that have improved, many of these go on to adulthood, and they present for the first time in adulthood also. Largely IEMs are classified into intoxication disorders, energy metabolism disorders, and storage diseases. Intoxication means the enzyme is deficient, so the substrate that is proximal to that enzyme will accumulate and cause diseases secondary to the accumulation of that substrate. Energy metabolism is when there are mitochondrial pathway or fatty acid oxidation disorders, which will deprive tissues of metabolites for cellular mechanisms. And so there is a energy metabolism disorder. And storage disorders is when, usually in lysosomal pathway disorders, where these products accumulate in lysosomes and cause cellular dysfunction. So this is just a classification of what comes into intoxication, what is energy metabolism, and what is storage disorder. Amino acid urea disorders, urea cycle disorders, galactosemia, fructosemia, porphyria, all of them come under intoxication disorders, where there is a deficiency in an enzyme pathway. Energy metabolism disorders are mitochondrial disorders and fatty acid oxidation disorders. And storage disorders are largely lysosomal or peroxisomal storage disorders. So when do you suspect IEM in an adult? Usually you suspect when it is a differential for new onset neuropsychiatric symptoms, when they present with acute encephalopathy, especially in catabolic circumstances like infections, fasting, physical activity, pregnancy, or childbirth. When they present with refractory seizures, especially those that are food triggered. When they present with young stroke or stroke that is not congruent to the vascular territory. And if they present with exercise intolerance, high levels of creatine kinase in the blood, recurrent attacks of abdominal pain associated with hyponatremia and neurological symptoms, we must think of porphyria, and extreme lethargy. These can be initial presentations in adulthood of IEMs. So this is a busy slide, but basically what I wanted to say is that each of these presentations that I spoke about earlier, you can think of all these IEMs in relation to each of these presentations. So when someone comes with acute encephalopathy or psychiatric, new onset neuropsychiatric manifestations, you should think of porphyria, urea cycle disorders, amino acidopathies. When they come with recurrent vomiting, again, urea cycle disorders and organic acidemias. When they come with young stroke, we would think of mitochondrial diseases. When they come with exercise intolerance, we would think of muscle glycogenosis or mitochondrial disorders or fatty acid oxidation problems. When they come with recurrent episodes of abdominal pain with neurological symptoms, we would think of acute hepatic porphyrias. And when they come with refractory epilepsy, again, it is mitochondrial diseases and urea cycle disorders. 2-3 tests that I wanted to highlight. When you suspect an IEM, it is good to do a blood lactate, venous blood gas with blood lactate, an ammonium level, and urine ketones, as well as urine and blood organic acid, amino acids. Now, 2 points I wanted to highlight here is ammonia need not always be elevated in a organic acid urea. Because the brain glutamine deposition happens before ammonia is elevated in blood. And the second thing is this Hoish test, which is a bedside test for detecting porphyria. It's done with urine and hydrochloric acid. The only porphyria that doesn't pick up on the Hoish test is this ALA dehydratase deficiency. So things that we have to manage acutely in patients who present with IEM in adulthood are hyperlactatemia, which will usually correct with fluid and caloric supplementation. And if required, very severe, less than 7.1 pH, we give sodium bicarbonate. Then the other thing is hyperammonemia. Sorry, the title is wrong. Hypoammonemia. We usually we reverse their catabolic state. We use ammonium binders like sodium benzoate and sodium phenyl acetate. And if it is very severe, we go for dialysis or hemofiltration. Okay. Thank you.
Thank you. This girl, what was the reason she presented to you? What was her problem?
The blackish discoloration of her clothes.
That's all.
Yes.
Nothing else.
Nothing else.
Then now you have referred her to clinical genetics.
Yes.
Is it? Sure. Any questions? Okay, we'll move on.